Hi, I'm Will Ratliff. I'm an innovation program manager at the Duke Institute for Health Innovation, and I'm representing our project team under Dr. Cara O'Brien and the Duke University Hospital Behavioral Response Team. I'm presenting our project, Predicting Behavioral Emergencies in the Hospital. This work focuses on addressing a growing problem facing our health systems across the country. That is, behavioral crises that lead to physical and verbal abuse against our frontline clinicians. The Bureau of Labor Statistics reported that injuries from violent attacks against medical professionals grew by 63% from 2011 to 2018 and has continued to increase since the COVID-19 pandemic. These events lead to bad outcomes for our patients, namely chemical sedation and restraints, and physical and psychological trauma for our clinical colleagues. Duke Health has recently formed behavioral response teams for its hospitals, who have been trained to better support hospitalized patients and de escalate potential crises before they occur. Our project team has trained machine learning models to proactively identify patients at risk of having a behavioral emergency during their encounter. We hope to apply this tool to support our behavioral response team colleagues in early identification and de escalation. To predict behavioral emergencies, we began by identifying our real-time behavioral emergency phenotype. The behavioral emergency phenotype is a union of specific orders and antipsychotic medications given at the time of a behavioral emergency. Among our 2017 to 2021 adult hospitalization cohort, it occurs in 0.9% of encounters. We have built 2 point-in-time models, a time of inpatient admission and a 24 hours into admission model, each which predict whether the patient will meet the phenotype later in that encounter. To validate our behavioral emergency phenotype, we compared it to a 7-month set of ground truth documentation on behavioral emergencies in the form of behavioral response team consult and event notes in May through November of 2022. Via a combination of overlap with documented notes and physician dual adjudication, we achieved 90% positive predictive value and 36% sensitivity with our phenotype compared to documented ground truth. Our current time of inpatient admission model has a performance of AUC 0.85 and AUPRC 0.11. It incorporates static variables such as comorbidities and chief complaints and summarizes temporal variables like blood pressure, pulse, drug screens, and psych consult orders. We have created our future state workflow under the guidance of our behavioral response team colleagues. We will generate a push notification for patients who have a high risk of having a behavioral emergency at the start of their encounter and again at 24 hours into the encounter. A behavioral response team nurse will review a patient's chart and perform a bedside assessment and will initiate a consult or event as needed with the listed interdisciplinary team. We plan to temporarily validate our model with our key stakeholders and will work with our behavioral response team to train and user test our paging solution. We are assessing our model for potential bias and working with our colleagues to ensure equity in our overall solution with the behavioral response team and its interdisciplinary team members. Thank you.